I'm re-recording this session because yesterday when I did this chat with the students, I made a mistake in the recording and it didn't work. So I'm just going to try to give the same information that I gave those students and recording it so that I can post it in the class for you to listen to. One of the questions that we had in the class uh, at the beginning was about the differences between guidelines. We're struggling again with the differences is what you're seeing in NSPTF and what you're seeing in different guidelines, and that is normal. You will find that NSPSTF is a little bit more loose or less strict, less monitoring than you will find in some of the professional organizational guidelines. For example, with the breast cancer or the mammogram screening, that was a big issue a couple of years ago that NSPSTF, which is a U.S. organization, a government organization, made recommendations based on cost and risk of false negatives, positives, and also the ability to prevent morbidity and mortality. And so they changed those mammogram guidelines, but uh, you'll find professional organizations publishing guidelines that require increased monitoring or more frequent monitoring than NSPSTF requires. And I gave some examples in here specifically of, and I did last week, but also this week. If you'll look at my posting in here, it talks about AAA and addresses this question kind of the same way. You see the NSPSTF recommendations here for AAA repair. And it says, for those 65 to 75 years who have ever smoked, that they should have a one-time screening by ultrasound. But in other guidelines, you may find that they recommend that you screen everybody. So my recommendation is that if you look at these if you read the guidelines on the NSPSTF and you go into clinical considerations in there, you will find and often that it refers to the patient condition. So we have guidelines that are a little less monitoring in NSPSTF and a little more monitoring from other professional organizations. And all of it is based on patient condition. So I would recommend that when you answer board questions, that you answer them from the NSPSTF guidelines, but also always remember that it's based on patient condition. If there are risk factors, symptoms, all of those things involved, there's another one here under peripheral disease that I'll show you, and I address this same issue in here. And this is a common thing that we struggle with as nurse practitioners because there's no one right answer. This is based on clinical judgment. So if you see peripheral arterial disease in NSPSTF, which is the U.S. Preventative Task Force, which they're dealing with the herd. They're dealing with the whole population. They're not dealing with just an individual. And what they're saying on peripheral arterial disease, that they conclude that there's insufficient evidence to do an ABI index, ankle brachial index, on every patient. But you'll see three other guidelines compared to USPSTF in our up-to-date readings, and they're maybe require a little bit more monitoring. And I think, to think your way through this, just take USPSTF guidelines and then add in patient condition. Think about those things in your patient that would cause you to do an ABI, that would indicate that you should do an ABI. And you can see in this one right here, there's clinical considerations. That's not a link. You'd have to go to the USPSTF website. Okay, so I wanted to go over that a little bit, and then I also wanted to talk a little bit about the case study. I've heard some frustration in there, and I know uh, that a lot of people have completed this case study and just fine, but some people are frustrated with it, and so I'm going to just kind of go in there and take a look at it with you and see what the problem is, or give you a little help on it. So in here, the instructions for the case study say to use Mozilla Firefox. And I know that some people say that they use it and it doesn't work, and I don't know why, but it works for me. And it says Internet Explorer works fine also. And so don't use Safari, use Mozilla for Mac. And then here's a student user guide. And this is not an exercise in learning soft chalk, and it's not an exercise in frustration. It's in order to help you apply those things that you're learning over these 2 weeks into a single kind of exercise. So I'm going to go in the cardiovascular case study as a student, and right now I see that I have an incomplete lesson. So I have 6 points, which I'm not really that concerned about the points. All I want to do is make sure that you worked your way all the way through. And I will be looking at these myself. I look at these gradings, and the grade is not in Blackboard. The requirement is that you participate. So I wouldn't spend a lot of time, trying to get a perfect score, because the idea is that you had an educated answer, that you did the readings and you did an educated answer. And if it doesn't work exactly like with the wording that you want, just keep going, because I'm going to look at these myself. So I'm going to launch my lesson. I've already started one. So now it's going to give me the option to resume my old lesson, which I'm going to do right here. And in my old lesson, I have scored 2 points, and I see my answers there. And so I'm going to go ahead right now and go to the last page, and I'm going to, for these that you have to type in, you have to click finish right there, but then there's a finish button at the bottom, that when I'm completely finished, I'm going to hit the finish button. And then it tells me my score, and I can even send it to an email. Okay? So, or I can print the receipt, either one. So I can do that. If you're not seeing this when you finish, there's some problem. Okay, so that shouldn't be happening, and you can contact me privately and we can talk about that. And I'm here to help you, and I don't want you to feel like this is an exercise in frustration, because it's really not intended to be that way. Okay, so I'm going to close that out, and now I'm going to see if I enter again. And now it says that I have, let's see, I'm going to launch the lesson. And what it says is it's starting a whole new one, because the other one was completed. So the other one is completely gone to me. But for me, when I went in with Mozilla, I could continue a lesson that I'd already started. So let me know what your problems are, and be assured that a lot of people have finished, and the score on the case study is not what I'm looking for. I'm looking for participation, that you answered the questions, and that you got in there and tried to learn through using that. Okay, so let's go on to the topical list. Now in Blackboard, I'm going to be releasing some in the office quizzes this week, and those are a little bit more focused on medications, just to get you involved in your readings again for your medications, and kind of give you some sample questions just to get you going. And in this assigned readings, you can see that I've given you some up-to-date readings on anticoagulation and that type of thing, and also just an introductory video to help you understand the coagulation cascade. I don't think that on the boards or any test that they would ask you about where the exo inhibitors and the direct thrombin inhibitors and warfarin or heparin are working on the cascade. the reason that I gave you that background so is you could understand the differences between the two where these medications fall on that cascade, where they're working on the cascade. And if you understand, often if you understand the pathophysiology and you understand the mechanism of action for cardiac drugs, and you understand them, how the drug mechanism of action acts on the patho or the normal physiology, you will be able to think your way through pretty much any question, and you will be a safe prescriber. And what I want you to know is I want you to read about those four classes: the exo inhibitors, the direct thrombin inhibitors, warfarin, and heparin. And within heparin is the low molecular weight Lovenox. It's a heparin. So I want you to read about those, just review the things that we talk about, the mechanism of action, contraindications, indications, just those things, the patient teaching, all of those things that you need to know to be a safe prescriber. Okay, so you're going to see a lot of the anticoagulation when you have people with valve problems or AFib, and I think just the majority of people that I have on anticoagulation are with uh, post thrombotic phlebitis, like a post DVT. They had one remotely, and or some sort of an aneurysm, and also atrial fibrillation. Those are the main reasons that in my practice, that people are on anticoagulation. So it's a big deal. But know the monitoring. Know what you need to check. Everybody knows on Coumadin that you're going to check a PTINR, and most people know the range that's therapeutic, and they know the antidote, which is good to know. But on these newer drugs like Xarelto and drugs like that, and Plavix, what is the monitoring for those? Do we draw a PTINR? Do we check a bleeding time? What do we do if they overdose? What if you have a patient who comes into your clinic and for a regular checkup and reports, oh yeah, well, I have blood in my urine this morning. So what are you going to do? And they're on Plavix or a drug like that. So you need to zero in on those type of things, because those are things that could really harm somebody. Okay, so abdominal aortic aneurysm. This is another, I think, I'm going to release that test blueprint this week, but there will definitely be questions on abdominal or aortic aneurysm. And you're going to want to know the screenings. Well, I just pulled up the screenings, and we talked a little bit about that, about the differences in screening. So who gets a screening? And it's ultrasound. Who gets a screening, and why? And also know when is it an emergency? Know the normal size, how you diagnose. And there was a video in there in the there was a video link to a YouTube video right here. So you're going to want to, that provides, the first half of it's pretty much primary care and just background, and that's really what you're going to look at. On these aneurysms, you're not going to want to go into the surgical procedures. You're not going to want to learn all that stuff. You want to take it up, focus on the screening, the exam, the presentation. When do you refer? When is it, kind of know the numbers? When is it big enough to refer? It's good to know, to have an idea of the normal anatomy, to know where these things are, but nobody's going to ask you, okay, an aneurysm originates in distal renal arteries. So is this an infrarenal aneurysm? I don't think it would be we're not going to ask sort of anatomy questions, because what we want to do is we want to know about evaluation and management, screening, prevention, those type of things. We're not going to be asking anatomy and physiology questions, but I think it's really good for you to review that and just know that it's there so that you can have a picture of it in your mind. Who does it happen in? Who is at risk for a triple A? So I thought this was kind of interesting right here, here's the risk factors when you're talking about reducing when you're talking about prevention. When you speak about prevention, you're talking about reducing risk factors. So you look at these risk factors here. That's going to also determine who gets screened. If somebody's at risk for it, you're going to be more inclined to screen for AAA. But also, these are the risk factors that you're going to mitigate. And we know that the natural history of AAA is that it progresses, it gets bigger. These aneurysms grow over time, and that's what we're going to expect. So you may have a small one this year, and in several years, you're going to monitor it, and it could grow, and it will grow. That's the natural history. So you look at these risk factors that you can mitigate or reduce. And I thought this was kind of interesting right here that the decreased risk of AAA is associated with females and people with diabetes and non-Caucasian. So now we have that overweight non-Caucasian with diabetes that doesn't have a risk factor. So I thought that was kind of neat. So it's only fair. Okay. So screening, we're going to get in that screening again, and we're going to look at asymptomatic, know when it's an emergency. Go ahead and read through these things, and we talked about that a little bit in discussion. How do you diagnose it? And what is the screening imaging? Okay, so we're not going to go so much into surgical repair, like I said, because that's not primary care. If I have a patient with a new aneurysm from my clinical judgment, I always collaborate with my physician. And then we decide whether to refer or not. I'm talking about non-emergent AAA. I will always collaborate and share the joy, share the responsibility. And so there was a little article on non-ruptured and how to manage those, but unless you're, really, really confident and have worked a lot with this, and your physician, you work closely with them and they have an understanding of your skill, I would always recommend physician collaboration on these. Okay, so the information for patients, and that's pretty much it on that article. And then there's some extra articles over here, and this is asymptomatic abdominal aortic aneurysm. Read that from the primary care role, the same thing. Screenings, those are the same thing, and there's your video. Okay, so cardiac arrhythmias. Now, somebody asked in the session if we were going to have strips. When we have the focus of this is not on the strips, but on the management of arrhythmias, identification of arrhythmias. But the focus is not on the strips. We may have a strip on there, but it would be the biggies. It would be the ischemia. It would be atrial fibrillation, flutter, the VTAC, the biggies, the things that would really, really, that you should be able to recognize in a strip. We wouldn't expect you to identify, a third degree heart block or something like that. That's not what this lesson is about. Okay, so a lot, like I said earlier, atrial fibrillation, you'll see that quite a bit, especially in your older patients, because anytime your myocardium stretches from heart failure, or it's damaged from ischemia or MIs, it can impede on that pathway, a conduction pathway, and you're going to see a lot of AFib in older people, especially people with those risk factors. So you're going to want to know about atrial fibrillation, and you're going to want to know about palpitations. How do you, because that you'll hear that, and that's one of the questions we ask when we're doing our review of systems. Any chest pain, palpitations? No. Any shortness of breath, cough? No. And they'll say, well, yeah, every once in a while I feel a bump, but so go ahead and look at that. Look at arrhythmias in athletes, and also palpitations, just for your clinical practice. Kawasaki's, when I took the test, it wasn't on the test. It wasn't on my boards, but we'll want to. This is usually oftentimes a pediatric problem, and you will want to know how to, diagnose Kawasaki's. You'll want to know that it's there. It'll be on the radar, and you'll want to know when it's serious and not, and when to refer, that type of thing. So clinical presentation, risk factors, all of those things, when to refer, how to care for this patient if they stay in your clinic. Okay. Okay, so peripheral disease, this is going to be important for you to read up on. There's several articles here that we've gone over, and there's some discussion in the course that I've given feedback on and talked a little bit, joined in on the discussion. And you're going to focus on the differences between the two problems, and we've talked about that a little bit. Let's go to those discussions. So let's go to those discussions and see so far what we've talked about. So let's go to those discussions a little bit and talk about these and see what we've discussed so far. Uh, Here it is, peripheral disease right here. And I'm going to go ahead and select all and then collect them so that I can. So the question was, how would you differentiate between a diagnosis of peripheral arterial disease, which is PAD, or peripheral venous disease, which is PVD? That's the terminology that we're going to be using for this course, and that's kind of the terminology that's out there. If you consider they're all vessels, sometimes you'll see peripheral vascular disease, which is PVD also. But for now, we're going to say peripheral venous disease to kind of differentiate between those two. Now, Christina did a good job talking a little bit about those differences, and then Samantha also highlighted them in by bulleting them. So peripheral artery disease, what I'm going to do is give you a little bit of a memory tip. Okay, peripheral arterial disease is when the blood is flowing into the leg. I know this seems basic, so if you know this, forgive me, but I sometimes like to have these memory things so I can think through things without trying to memorize them. I'm going to think about it. So peripheral arterial disease is blood flow into the leg. And when you don't have enough blood flow to a limb, it's going to have decreased pulses, it's going to be pale, decreased capillary refill, all those type of things. And so if a person is standing up, they're going to have more blood flow to the leg because of gravity. And if they're using the muscle and they don't have enough blood flow, they're going to get pain in the muscle. But generally speaking, when they're standing up or they lower the extremity, they're going to have more blood flow to that extremity. If they elevate the leg, then they may have decreased blood flow and they may have more ischemia. So dangling the extremity or putting it down may increase the blood flow or perfusion and decrease the pain. On the other hand, with venous disease, with the veins, in the lower leg, in the lower extremity, the valves are incompetent and they're not pushing the blood back from the leg into the general circulation. And the blood is getting trapped down there in the lower leg. And therefore, when they're on their feet and blood is flowing, when they're standing up and blood is flowing to their feet more easily because of gravity, then and also it's harder to flow out because of gravity and because of those incompetent valves. Then they're going to have swelling when their legs are down. So venous disease, there's usually swelling in the leg. In arterial disease, you won't see the swelling because there's no blood to seep out or get trapped down there. Now, elevating the extremity in venous disease helps by gravity, to have the blood flow out of the leg. And the edema will reduce. So that may reduce the pain. So think about it. If that helps, I'm glad. And I like the list of symptoms that you've had there. And also think about the difference between an emergent problem and a non-emergent problem. When you have peripheral vascular disease and particularly peripheral arterial disease and venous disease, you're going to see more, venous disease, you're going to see more of skin problems, a lot of times swelling. But in the arterial problem, you could have a chronic peripheral arterial disease, or you can have acute peripheral arterial disease. So know the difference there. And I think that there's a little mnemonic that you can learn for that, and I might have put it somewhere, but I think it's in our readings. It's pulselessness, pallor, pain. It's like the 5 Ps or something like that. So that might help you remember those things, but that's an emergency. So you'll want to know how to differentiate between chronic peripheral arterial disease and acute peripheral arterial disease. Okay, so those screenings, I showed you this screen a little while ago and talked about the differences in screening, and the screening method is ABI. And so I put a little picture down here with a link to and right click on this link right here and click open in a new tab, and that will take you there. And it's just going to discuss the numbers. It's going to discuss, the ratio. This is a ratio. And so it's going to discuss these lower numbers versus the higher numbers, but it's also going to give you a picture of how to do this. So you can see that this is not something that's just real quick in the office. You've got to have a Doppler, you have to have equipment, you have to have people trained, and you have to be able to evaluate the results. And I think that that would be something that would be, you don't really need to know the procedure very well, but just kind of know what it is, but know how to interpret results. I think that would be important. And I just put a picture here to kind of pique your curiosity. And so if none of y'all have seen those before, how that's done. And it's not just, that's why when you look at those, if you think about NSPSTF, they are weighing the benefits, risk, and cost. Is it worth it to screen everybody with ABI? Well, that would take a lot of time. And so they're saying, well, we're not finding enough evidence to perform this procedure on everybody. So that's where your clinical considerations come into effect. Okay, so let's look a little bit more of these. We're going to look at peripheral vascular arterial disease, wounds, know how to differentiate between a wound that is from our arterial wound versus a venous wound. Look at those things a little bit. Don't get a lot into, but the next thing that's going to be really a big risk for your patients. So let's talk a little bit about DVT management, identification in the primary care setting. What is our role, and what are we going to be doing? What are we going to be looking for, and when do we refer? Do we treat? All those kind of things. This is something that is high risk for your patient and something that you need to have on your radar and understand. Okay, so let's go to that article here, and you can, the article summarizes and gives you nice background, and that's what I like about these articles is they give you that, natural history, the epidemiology, the underlying problems and the risk factors, all that kind of stuff. And let's look at the algorithm here. I like this algorithm, and hopefully it will, let's see if it's going to get bigger. There we go. Hopefully you can see that. Okay, so looking at the algorithm for DVT, we're going to move through this just a little bit and kind of think about it. A proximal DVT is above the knee, and a distal DVT is below the knee. All proximal DVTs, you can see, they should have anticoagulation. And if they can't because of contraindication, then they're probably going to be a surgical case. They're going to have an IVC filter. If there's no contraindication and they have or don't have this phlegmasia cerulea dolens, that's hard for me to say. I don't know the correct pronunciation. I'm doing it phonetically. But that's when you have so much swelling from the DVT that you have a white leg, or there's not enough circulation to the leg because of the DVT swelling. So if you have this, then you're going to, that's going to be an urgent, you're going to send them off. And then, but if they don't have that, then you're going to anticoagulate. And heparin, you can use the low molecular weight heparin, which we all know is Lovenox, and warfarin, or you can put them in the hospital for IV heparin. Remember, all the patients were, they were bed rest and they were 3 days and they were on a heparin drip and then, or heparin IV, and then they would start on Coumadin. And then, because the heparin protected them until the Coumadin was therapeutic. So as soon as they were therapeutic on the heparin, then, I mean, on the warfarin, then they could go home. I don't, but, we have patients with DVT that are not in the hospital. So that's a decision. If you have a patient with the DVT, you need to, with a confirmed DVT, you need to talk to your collaborating physician and work together on a plan of care. Okay, because if this person needs to be admitted, then they're going to have to, the physician's going to have to be involved in that. Unless your physician doesn't admit, and then sometimes what they do is they transfer them to the ED, or they have a hospitalist take over, whatever, but you're going to need help with this. And so also alternatives are factor XA inhibitors and direct thrombin inhibitors. Those are also being used, but traditional is the heparin warfarin combination. And so let's say in the distal DVT, they're asymptomatic. Let's get over on this side. They're symptomatic and they're going down that same, and no contraindications, going down that same pathway. Well, if they're asymptomatic, they don't always get treated. So one of the students today posted something in there about this, and I thought that was kind of interesting because I had the same reaction as she did. Um, is the DVT extending towards the proximal distal veins? Is it growing? Is it moving up there? Is it an unprovoked event? And that means that this patient, you can't find any reason for them to be having this DVT. They didn't take a car trip. They don't have, a hypercoagulability. There's no risk factors. And it's just an unprovoked DVT, just kind of random. You want to make sure that those get anticoagulated unless there's contraindication. And then if they have a contraindication of coagulation, or they just refuse it, they don't want it, they have the option of choosing to observe and continue to do testing, the ultrasound to see. And if it doesn't grow, you don't have to anticoagulate. And if it's stable, just continue to serve, to monitor it. Now, this is what you need to know down here too, because most patients will get 3 months of anticoagulation, but some are longer, and some end up with this. You'll end up with a patient and who's been on anticoagulation for, you don't even know how long, because the record doesn't go back that far. And then you ask why they're on anticoagulation. They'll say, well, I had a DVT in my calf. And you'll say, well, weren't they treated? But a lot of times they get this post-thrombotic phlebitis thing going on, and it's persistent pain and that type of thing. So just know that even though your patients may have had a remote problem, they may be on long-term anticoagulants. So again, look at your drugs on those. Look at the drugs on those. Know your assessments. Know when to refer, and that type of thing. Okay, so valvular heart disease. I didn't assign a lot of readings on valvular heart disease. I did give you an evaluation method for evaluating heart murmurs, which I think works really well. But Taro is really very comprehensive, and I like that resource for this one. It also includes the across the lifespan in the children a little bit more, so you might want to read that. And again, on valvular heart disease, you're going to be looking at evaluation. When is a heart murmur serious? Is it innocent? Is it serious? Is it a problem that needs to be looked at? Now, I'm going to say in all of my patients with a new heart murmur, I collaborate with my physician, and my physician actually sends them to cardiology just to, or he'll go ahead and order his diagnostics, but he works up every new heart murmur, of course. He'll do the workup on them. So look at that a little bit, but some nurse practitioners will feel perfectly comfortable. It depends on their practice in handling these, but I would recommend that you collaborate on all new heart murmurs. And really what you want to look at is identifying the murmur, going through and figuring out, okay, where is it heard the loudest, which listening point? Because if it's heard at the mitral listening point the loudest, then it's a mitral murmur. If it's heard at the aortic the loudest, then it's an aortic murmur. In the pulmonic area, often what you'll have is atrial septal defect. And these typically don't have symptoms until middle age, and then sometimes you'll get congestive heart failure with those. Those are, those are the main ones. Usually you're going to see mitral and aortic. And you can hear that described as you have a patient with a murmur heard loudest at the apex. And so if you have a murmur heard loudest at the apex, it's a mitral murmur. If you have one heard loudest at the aorta, it's an aortic murmur. That's pretty simple. So then the next thing you want to do is figure out the cycle. When is it heard the most? When is it heard during the cycle? During the systolic or the diastolic phase of the cycle, the cardiac cycle. And oftentimes you can hear this with your stethoscope if the heart rate's not really, really fast. You can hear whether it's going sh boom or boom sh boom sh. And but sometimes you can't. So if you can't hear it, then put your fingers on the carotid and listen and feel and listen at the same time. And that will help you figure out where in the cardiac cycle this murmur is occurring. So you're already really smart, right? You're listening to a patient and you say, "Oh, I have an aortic murmur. It's a systolic aortic murmur." Well, that's pretty good. I mean, if you know that, you know a lot. So you're going to do that with your hands on, okay? And then you're going to figure out how loud it is. So there's a grade. You hear this, you see this on grade 2 out of 6, grade 3 out of 6. And so you're going to just read these over and kind of know that 1 is the lowest intensity and 6 is the loudest intensity. And then there's several mnemonics for figuring out. I've put several mnemonics that I found online for helping you to remember murmurs, and whether they're systolic or diastolic, because diastolic are always bad. So you really want to know if you have a diastolic or systolic murmur. That's really important. Here's some mnemonics. I've posted some of those in there. They can help you. I know Amelie Hollier has a nice mnemonic for remembering whether something is a systolic or a diastolic murmur. So it's important that you know the difference between these two, and which is, that the diastolic is always serious and you need to have those evaluated. In here, I provide a little chart to show you that, and some of the, just some little flashcards that you can do to get you into your readings. Also, you're going to want to look at antibiotic prophylaxis. In the article that was assigned here on valvular heart disease, there is a link to another article, and I'm showing this article here, and it's about prophylaxis. And what you're going to have to decide a lot of times when you have patients with valve problems, that's what you're going to be asked for, is these prophylactic antibiotics. And so it's usually amoxicillin. That's usually the drug of choice, and it's to prevent infectious endo. The primary reason for treating with antibiotics is to prevent infectious endocarditis. We know that people are more likely to get infectious endocarditis from just frequent exposure to bacteremias. But we also know that prophylaxis with antibiotics before dental, GI, or GU procedures may prevent some cases of infectious endocarditis. So what we do is we prescribe those antibiotics before they have those type of procedures. So know the first line is amoxicillin, and then you can look at if there's an allergy to penicillin, what to give. And but the main thing is who gets it? Who gets those antibiotics before those procedures? So look at that and make sure that you review those because that's where you'll be most likely to be come into contact with management of valvular disease. And when you talk about valvular disease, you get into heart failure and all those other kind of things, which but we're going to kind of look at it independently here a little bit. Okay, so that's pretty much the what we have going on. I'm going to post that blueprint for test 3, and it's not going to give you a ton of information more than you already have, but it'll tell you how many questions are on each one of these topics. And then it'll also list some, drug classes that you need to go over. So don't hesitate to ask questions in the course, and let me know if you have anything going on. I will be online probably tomorrow. Sunday I won't be online, but I'll be online tomorrow. So let me know if you need anything. Thank you.